Learn the 4 must-know clues to identifying a challenging case of resistant hypertension. EndlessMedical.Academy educational case. Content created, reviewed, and approved by Lukasz Kiljanek, Doctor of Medicine, Board-Certified Nephrologist, Certified Hypertension Specialist, Internal Medicine Specialist. See video description for disclosures. An 87-year-old man is evaluated for recurrent episodes of abrupt dyspnea and severe hypertension. His history includes chronic kidney disease, retinitis pigmentosa, panic disorder, remote inguinal hernia repair, remote cutaneous leishmaniasis, and treated vitamin B12 deficiency. He currently smokes 1 pack per day and previously smoked as many as 3 packs per day for 30 years. He has been in recovery from opioid use disorder for 3 years and recently returned from Europe. He has no known allergies. His mother had a stroke at age 71. His medications are valsartan 160 milligrams daily, amlodipine 10 milligrams daily, torsemide 20 milligrams daily, carvedilol 12.5 milligrams twice daily, sertraline 50 milligrams daily, extended-release naltrexone every 4 weeks, and cyanocobalamin 1,000 micrograms daily. Despite observed dosing during a recent admission, systolic pressure remained between 170 and 205 millimeters of mercury. Today, his pulse is 123 per minute, temperature is 36.2 degrees Celsius, respiratory rate is 17 per minute, blood pressure is 203 over 105 millimeters of mercury, and oxygen saturation is 96% on 2 liters per minute nasal oxygen. He has an abdominal systolic bruit, bibasilar crackles, and trace ankle edema. Peripheral visual fields are constricted at baseline. There is no papilledema or focal neurologic deficit. Estimated glomerular filtration rate is 24 milliliters per minute per 1.73 square meters, normal at least 60 milliliters per minute per 1.73 square meters. Potassium is 4.3 milliequivalents per liter, normal 3.55.0 milliequivalents per liter. Urine albumin to creatinine ratio is 180 milligrams per gram, normal less than 30 milligrams per gram. And B-type natriuretic peptide is 680 picograms per milliliter, normal less than 100 picograms per milliliter. A recent echocardiogram showed concentric left ventricular hypertrophy, an ejection fraction of 55%, and no severe valve disease. A prior abdominal magnetic resonance imaging showed a 7.2 centimeter left kidney and 10.8 centimeter right kidney without an adrenal mass. The study was not an angiographic examination. Which diagnostic study is the best next step? Option A, proceed to catheter renal angiography with selective renal arteriography and translesional pressure gradient measurements. Option B, obtain iodinated contrast-enhanced computed tomographic renal angiography as the initial vascular examination of both kidneys. Option C, obtain renal artery duplex ultrasonography with peak systolic velocity, renal aortic ratio, and resistive index measurements in both kidneys. Option D, obtain gadolinium-enhanced renal magnetic resonance angiography with a Group 2 contrast agent as the initial vascular examination. The correct answer is option C. Obtain renal artery duplex ultrasonography with peak systolic velocity, renal aortic ratio, and resistive index measurements in both kidneys. The combination of resistant hypertension despite observed therapy, recurrent abrupt dyspnea with congestion, and abdominal systolic bruit, heavy smoking exposure, and marked renal asymmetry strongly suggests renovascular hypertension from atherosclerotic renal artery disease. The left kidney is only 7.2 centimeters compared with 10.8 centimeters on the right, implying chronic unilateral hypoperfusion. Renal artery duplex ultrasonography is the best initial vascular study because it can assess peak systolic velocity, the renal aortic ratio, intrarenal resistive indices, kidney size, and bilateral hemodynamics without iodinated or gadolinium-based contrast. Gadolinium-enhanced magnetic resonance angiography can provide anatomic vascular imaging, and Group 2 agents have a favorable safety profile, but an estimated glomerular filtration rate of 24 milliliters per minute per 1.73 square meters makes a non-contrast initial study attractive when technically feasible. Computed tomographic angiography requires iodinated contrast and exposes the patient to a potential kidney insult. Catheter angiography is invasive and is generally reserved for non-diagnostic, non-invasive testing or when an endovascular procedure is being seriously considered. In summary, the clinical pattern has a high pretest probability for renovascular disease. Duplex ultrasonography offers useful anatomic and physiologic information without contrast exposure. More invasive or contrast-enhanced tests can follow if the duplex examination is inadequate or discordant with the clinical picture. Primary teaching point: recurrent flash pulmonary edema, resistant hypertension, and abdominal bruit and asymmetric kidney size are high-yield clues to renovascular hypertension. Secondary teaching point: test selection should account for kidney function, procedural risk, local expertise, and whether intervention is contemplated. Don't forget to like, subscribe, and share. Content created, reviewed, and approved by Lukasz Kiljanek, Doctor of Medicine. See video description for disclosures.